About that weird rash. Skin manifestations are one of the most common medical complaints. We've been taught to think of skin manifestations as a dermatology issue. But did you know that one of the earliest ways to find out that if you have an urgent hematological condition is by recognizing a specific type of skin rash? I'm talking, of course, about platelet disorders. This is probably one of my favorite pathology topics. So by the end of this lecture, you should be able to, number one, identify how platelet disorders are generally classified and their universal clinical manifestations. Number two, explain the underlying disturbances to normal physiology that result in the pathogenesis of these conditions. Number three, recognize the unique diagnostic tools that can be used to identify these pathologies. And number four, predict the expected change in lab values in these differing conditions. So let's start with a few general observations before you dive into individual pathologies. Platelet disorders can either be quantitative, qualitative, or both, meaning that either they happen because you lose a number of platelets, because you lose the function of platelets, or both happen at the same time. Regardless of which one it is, the end result is prolonged bleeding time, and small forms of bleeding like petechiae or purpura, epistaxis, which is nose bleeding, and mucous membrane bleeds. So let's start with our first condition, Bernard-Soulier syndrome. This is a dysfunction of the GP1B structure. So this impairs the ability of platelets to adhere to von Willebrand factor. So for quick review, when it comes to primary hemostasis, or the ability of platelets to come together, the von Willebrand factor will bind to some subendothelial collagen in a damaged blood vessel. And this will bind to GP1B, which is an anchor protein or an anchor molecule found on a platelet. And this will cause the process of adhesion. In Bernard-Soulier syndrome, you have dysfunction of GP1B. So in this disorder, would you expect a drop in the number of platelets? No, you'd see a normal platelet count. And therefore, this is considered a qualitative condition, as there is a dysfunction in the platelet structure itself, notably GP1B. This results in a long bleeding time with a normal platelet count. There is one specific lab that is very specific to Bernard-Soulier, and that is called the ristocetin test, or the ristocetin assay. Ristocetin is a molecule that binds von Willebrand factor to GP1B. It pretty much glues these two together. So obviously in Bernard-Soulier, because your GP1B is dysfunctional or defective, well, the ristocetin would also be abnormal. On a blood smear, you'd have big platelets. Very common mnemonic for this is in Bernard-Soulier, you get big suckers for big platelets. And this is because the platelets are released from the bone marrow in an abnormally large size. The next condition is Glanzmann thrombasthenia, which is very similar to Bernard-Soulier. This time the defect is in GP2B3A, which is right here. And this is due to a defective integrin protein that prevents it from being anchored properly to the membrane. So as a consequence, we do not get platelet aggregation. These platelets are unable to stick to each other because they cannot bind this linking molecule fibrinogen. Again, we have a qualitative problem, as there's nothing wrong with the platelet count themselves, but rather there's something wrong with the platelet. And so as a result of this, we have a long bleeding time with a normal platelet count. And lastly, when it comes to blood smear, you're going to see platelets clumping together. Now let's talk about the condition that'll take our most time today. ITP, or immune thrombocytopenia. Everything you need to know about this disease is hinted by the name. This is a quantitative problem, hence the thrombocytopenia, and is due to immune destruction of platelets. This happens because of anti-GP2B3A antibodies. So here's a platelet with GP2B3A on it. Now you have an antibody to this GP2B3A. This attaches the platelets and sequesters them into the spleen. And it is in the spleen that they are destroyed by splenic macrophages. This can be caused by a number of things, like chronic autoimmune conditions like lupus, viruses, cancers, or it could just be idiopathic. It happened because of reasons we don't know. In kids, it's usually after a viral illness or it's idiopathic and it resolves on its own. On labs with these patients, you're going to see low platelet count with a high bleeding time. And on a bone marrow biopsy, you're going to see a large number of large megakaryocytes. This is because the body is attempting to replace the missing platelets. And and so it ends up producing more and more megakaryocytes. The way you treat these patients is with steroids. This will suppress the immune system, or you give IVIG, or intravenous immunoglobulin. The idea behind intravenous immunoglobulin is it pretty much gets sequestered itself to the spleen, and then it gives the spleen something else to eat up instead of our defective platelets. There are other drugs that also are used to treat immune thrombocytopenia, like rituximab, eltrombopag, or romiplostim. And lastly, if you can't figure out what to do with immune thrombocytopenia, if it's refractory, you can do a splenectomy. If there's no spleen, then there's no destruction of platelets. All right, let's wrap up by doing a quick flash quiz. Match these disorders to the underlying pathophysiology. Bernard-Soulier, Glanzmann thrombocythemia, and immune thrombocytopenia. Pause the video and then we'll come back to this. Okay, Bernard-Soulier is due to defective GP1B. Glanzmann thrombocythemia is due to a defective integrin protein, which causes a GP2B3A defect. And immune thrombocytopenia is due to antibodies against GP2B3A that causes splenic sequestration and destruction. So now let's quickly recap before we end this video. So, to wrap up, first of all, platelet disorders are either considered qualitative, quantitative, or they're both, and they're characterized by prolonged bleeding time and microhemorrhages. Bernard-Soulier is due to a GP1B defect, causing an abnormal ristocetin assay and large platelets on blood smear. Glanzmann thrombocythemia is due to inability to bind GP2B3A, causing abnormal platelet aggregation and clumped platelets on blood smear. And lastly, immune thrombocytopenia, or ITP, is due to antibodies against GP2B3A, causing splenic sequestration and destruction, and is treated with IVIG and steroids. That's pretty much it for our video on platelet disorders. If you like this video, please be sure to leave us a thumbs up. Thank you.